All right, we've got 32 folks online. We're gonna get started here. Again, my name is Mike Yudell. I chair the Department of Community Health and Prevention at the Dornsife School of Public Health at Drexel University. I am a historian and ethicist of public health by training, and conduct research right now primarily in the area of autism, ethics, and history. But that is definitely not what we are talking about now. Today we are gonna, with our two incredible guests, talk about the way in which historical and ethical concerns can help us understand and think about the challenges we are facing in the middle of the current pandemic of coronavirus. So please get comfortable and be ready to ask some questions. There is a Q&A chat box on your screen. Please feel free to send us questions while we're talking. I will be taking a look at those. I'm gonna let the three of us chat for a bit, and then we will dive into your questions. We're gonna start with some introductions. We are really lucky to have today Drs. Janet Golden and Dominic Sisti. Janet is a professor emerita of history at Rutgers, Camden. And Dom is a professor of ethics at the University of Pennsylvania. I'm going to give them each a few moments to introduce themselves and tell us a little bit about the expertise they're going to bring to bear to this discussion, and then we'll get started with some Q&A between me and the two panelists, and then we'll open it up to you guys. So Janet, you want to get us started here?
Yes, as Michael said, I'm a historian of medicine, and I guess you could say I'm always looking to the past with questions, but I also have bad timing because in November, I sent in an article about the 1918 influenza epidemic. It came out, probably went nowhere, and then boom, here we are. So it's something I published on a bit, and I'm always thinking about the parallels between that epidemic and our current pandemic, not so much in terms of what do the viruses look like, but in terms of how do we as a society respond to threats? And I'll go over some details in a minute, but go ahead, Dom.
Great, thank you, Janet.
Thanks, Michael. Thanks, Janet. Hi, everybody. My name's Dominic Sisti. I'm with the Department of Medical Ethics at the University of Pennsylvania School of Medicine. My main line of research is around psychiatric ethics in the behavioral health field. I'll be talking a bit about that today, but I also do a lot of work and teach clinical ethics. So we'll have to, I think, spend some time talking about the clinical ethics dilemmas that are unfolding before our eyes. Things that we in bioethics typically used as thought experiments. And frankly, in my career, I never thought I would see a time when these thought experiments actually became real life. And so here we are. And I appreciate the opportunity to talk with everyone.
Great, thank you, Dom. Thank you, Janet. Start by rooting us in history a little bit, and then turn to Janet for a few moments. Behind me, you would see my messy living room if I didn't have the special Zoom backdrop feature on my computer. But what you're looking at is an image from the September 28th, 1918 Liberty Loan Parade that took place here in Philadelphia. You may know that Philadelphia was the hardest hit city during the 1918 flu pandemic. And Janet, if I could start with you, if you could tell us a little bit about why that was the case and how politics played such a central role in the way in which the 1918 flu epidemic evolved here in Philadelphia.
Well, it's a pretty simple story. We have our first influenza case in early September at the Navy Yard, and thereafter the numbers of both military and civilian deaths in the city start to grow. But we're coming to the end of World War I, and we're raising money for that war with Liberty Loan drives, and Philadelphia decides to host a Liberty Loan parade. 200,000 people, as you see behind Dr. Yudell, come on out for that parade. Now, prior to that time, the Surgeon General of the United States, Rupert Blue, had said, influenza is a crowd disease. We have to cut down on crowds, but the city, as health commissioner, the mayor, everyone agreed that no, we can have the biggest parade ever. People came out, and a week later, the death rate from influenza spiked in Philadelphia, and it remained the hardest hit city. I want to say a little more about the federal-state relationships in Philadelphia, because I think that is instructive. That was a point at which the federal government issued a warning. The city didn't learn. But later on, when the city needed help, there had been one morgue in the city of Philadelphia. It held 36 bodies. Obviously, in the pandemic, that wasn't enough. And bodies started piling up. They actually had to open the door of the morgue to get the smell out of there so people could work there. A lot of embalmers quit or died. And the federal government actually sent embalmers to Philadelphia to work out of what were 5 hastily erected morgues. And volunteers actually stepped up to become grave diggers. So I think it tells us that local and federal relations were crucial back then, as they are today. I have to say, when I first wrote about this, I never imagined that, having seen the FEMA trailers after Katrina and now seeing them at the Elmhurst Hospital in New York City, I never thought we'd enter a situation like that where we'd run out of ways to care for corpses. But I guess we're back there again. So that's been startling to me.
Can you talk a little bit about and I think those are all important points and they're relevant to some of the federal state issues that we're facing now, and let's circle back to those in a second. But talk a little bit about the parade and why that went forward, and maybe some of the tensions between politics and public health expertise.
Well, it really was not as controversial as people claim. I mean, the city really did agree this would be a good thing to do. It would put Philadelphia, #1 on the map. What a great thing. And people were told not to worry. Commissioner Cruzen said, no, don't worry about it. It'll be fine. So it was really a matter, I would say, not of a conflict between different branches of leadership in the city, but an agreement that if we do the optimistic things, if we do the good civic work, if we're optimistic, it should be okay. It should be okay to gather. That was really the crux of the problem. So it wasn't as if, now the federal expertise was, of course, giving a different message. But we had a pretty strong health department in Philadelphia. A lot of cities didn't have them in 1918. We had a city health department. We had a state health department. So it felt like we had the right infrastructure. And there wasn't much to worry about. And I'll point out, of course, with World War I on, thousands of our doctors and nurses all over the country and from Philadelphia were overseas. So we didn't have much of a medical infrastructure in place. And that is going to contribute to the problems going forward.
So in the wake of that parade, Philadelphia death spike, more than 12,000 deaths in the city within a few months.
Right. The epidemic was a quick one, relatively speaking. So by Armistice Day, November 11th, the death rate had really dropped off. But yes, there were about 12,000 deaths in Philadelphia overall. The week afterwards was after the parade was the deadliest week. But I want to point something out, because it's come up with our current influenza COVID virus as well, and that is these viruses, which, by the way, our own president said, oh, it's just like the flu. That's what they said in 1918, like, oh, it's just seasonal flu. But these viruses live in the body a long time and can have lasting effects. So we know now from follow-up epidemiological data that survivors of the 1918 influenza pandemic had much higher rates of Parkinson's disease in old age, much higher rates than people who were not exposed. So we have to question what will be the long-term effects of having had the COVID virus. And where will our support and our medical services come to care for those people who survive the virus, but may have lingering effects?
Yeah, that certainly would apply, certainly in the short term, to folks who have lung damage from being on respirators long-term and other issues that come with that. Jan, I want to ask you one more question, and then we can shift to Dom for a bit. Are there other historical precedents that you think can shine light on today's events as we think about the relevance of history to this pandemic?
Well, when I heard the president refer to this as the Chinese virus, it of course reminded me of the outbreak of bubonic plague in San Francisco, which is blamed on the Chinese. It reminded us, of course, of labeling 1918 as the Spanish flu, or during the war as the Hun flu because of our German enemies. It reminded me of the yellow fever epidemic in New Orleans, where the people up in Memphis tore up the train tracks so nobody could migrate from New Orleans to Memphis. So this idea of we'll stop people from coming across the border, the state line, we'll label it as an outside enemy. That all seems very, very old to me.
The stigma and discrimination issue is certainly one that we as historians have seen repeatedly in pandemics, even dating back to the 1793 yellow fever epidemic, where it was the French who brought yellow fever to the US. So these are certainly dangers that we should consider, and remember that diseases like this don't discriminate in terms of who they can infect, but at the same time, we know both from history and current day that patterns of infection and the impact of disease can fall along historic lines in the context of health disparities.
Absolutely. Yes. And I think we're going to see a tremendous amount of that with this current epidemic, because it's a disease that appears to attract people with compromised lung function. And we know that in minority communities, Native American, African American in particular, not for reasons of what people would call race, but because of socioeconomic and environmental living conditions, it's going to impact them much more seriously. I just heard a report from somebody on the Navajo reservation. It's having a tremendous outbreak there. So this epidemic, like all epidemics, will underscore disparities in disease. And the question is always, for me, what are we going to do about it?
Yeah, I was talking to a reporter earlier about this issue and about the fact that some states are not collecting demographic data as this crisis is unfolding. And what does that mean? Especially when we look at some of the zip code maps of where the disease, particularly in New York right now, and slowly in the American South, where the disease is presenting itself. And given that this is a disease that preys on individuals with pre-existing conditions like kidney disease and heart disease and lung conditions, and immunocompromised patients, patients with hypertension, those are diseases that unfortunately, fall heavily along in disparate ways. So you see poor patients suffering disproportionately from many of those conditions, and you see members of the African American community, the Navajo community, indigenous communities, as you mentioned, all face higher rates of certain diseases that are, of course, associated with poverty. It's not about somebody's skin color or self-identified race. It's about the way in which poverty interacts with racism.
And to density, population density. So when we look at the outbreak in New York, in Queens, that is a heavily immigrant, very dense neighborhood. And of course, 1918 was probably one of the peak years for immigration to the United States, resuming after ship traffic started to resume after World War I. So we had a huge immigrant population then. And of course, they were as we know, blamed for a lot of the spread of disease and for disease.
Yep, and that had been an issue dating back to the early 20th century, late 19th century with tuberculosis, particularly in big cities. So this is nothing new, and we're going to see this play out very quickly. New York is unfortunately the first example of it in the US, but I suspect that it will play out in similar ways in Philadelphia, which remains the poorest big city in the United States. And we will see it play out in other cities as well. There was a really interesting article in the Atlantic today or yesterday about how some are predicting the pandemic will play out across the American South, where there are higher rates of many of these chronic diseases that seems to attract, where the risk factors are much higher for patients who contract COVID. Dom, I want to, and thank you, Janet. Dom, I want to turn to you for a few minutes. One of your specialties is healthcare and mental health care in the context of ethics. One of the things that I've been seeing both in the news and with friends and colleagues is the way in which the intensity of this moment, whether it be watching the increase in numbers across the United States and across the globe, whether it be the morgue trucks that Janet was talking about earlier and the high death toll that it is taking and in this time period, how that's weighing on our mental health. And I'm wondering if you can give us some context to that and also talk about how we might think through some of these challenges, given some of your own work.
All right, so there's a lot there. The crisis text line, which is an organization based in Manhattan, but has a global network now of crisis intervention specialists who are at the ready via text, reports, and I serve on a data safety board for them. I got an email about a week ago reporting that they've seen an uptick in service usage with high levels of keywords around anxiety, depression, fear, and uncertainty. Certainly, and so using their data as a proxy and just kind of common sense, we know that folks are on edge, and as this thing goes on, we're going to become more and more on edge. The key problem here is the isolation, the inability to see and spend time with friends and family, and the obvious problems of illness of friends and family and death. And so Governor Cuomo asked mental health care professionals to volunteer to serve on what's essentially a statewide kind of medical corps to provide telehealth services, telemental health services to anyone who calls the New York hotline. So I think, he's really got a line on this issue and is getting out in front of it. I think every state needs to do that. I think we're going to need an army of behavioral health clinicians who are at the ready to handle challenges in everyone's lives, in the homes of everyone, from anxiety around parenting and stress about work and family to individuals who have a serious mental illness, like say bipolar disorder, and maybe are having trouble getting the medication they need because they can't get out, and all the way up to folks who are institutionalized, and how we handle individuals who are in places that would be very dangerous. I'm working with some folks down in the Department of Health and the DA's office, looking at ways to decarcerate or move people out of the city jails. CFCF, Current Fromhold Correctional Facility, for example, has reported several cases, not as bad yet as it is up at Rutgers in New York, but it's just a matter of time. And so, a lot of individuals inside jails and prisons have mental illnesses. So we're going to need to grapple with a two-pronged issue here, which is helping the folks find safety who are right now incarcerated, releasing folks who are not a threat to public safety, and then getting folks who have addiction or mental health problems the treatments they need in this sort of strange environment where no contact or very little contact is allowed. So there's a whole range of challenges on the mental health front, dealing from folks in their homes to folks in institutions and other places. And then there's the even more, I think, disturbing and pressing problem of our frontline healthcare workers who are now experiencing and will be experiencing significant trauma as they witness to decisions that are incredibly difficult to make, decisions that are typically made on battlefields in faraway places. These are decisions of triage, where you're deciding to take a resource like a ventilator and give it to one person over another, using an algorithm, a decision guide that's rooted in ethical principles, but is nonetheless really grueling and emotionally taxing to implement. And so, we'll be probably dealing with the sequela of this pandemic on everyone's psyche for years to come. And I would expect there'll be a aftershock of PTSD and other trauma-related disorders, as well as potentially exacerbations of addictions and potentially new addictions, as folks look for ways to self-medicate the anxiety and fear. We could find ourselves, I spoke with a colleague of mine out at the University of Michigan who studies benzo addiction, so Ativan and these anxiolytic anti-anxiety drugs. And, that to me is one of the worries I have, is that folks are going to start to self-medicate with lots of benzos and other drugs, leading to a longer term problem. So there's any number of facets here that, that relate to mental health care, that this pandemic is going to illustrate and highlight, again, disparities in access to mental health care, disparities in how our mental health care is funded or not funded. All the gaps in our mental health care system are going to be are going to shine brightly in this moment, as we see the need for adequate supply of mental health care that just doesn't exist. And so it's going to be a difficult time. It'll be a challenging time, though there are steps being taken by folks like Governor Cuomo and others to begin the process of addressing these issues. But this is going to be like kind of the second wave of, or there will be a second wave of the pandemic is the second wave of the pandemic, but this will be a concurrent wave of mental health care challenges that we'll need to face.
Dom, I want to follow up with a few questions, and then there's a question from the audience as well. First, you briefly mentioned some of the challenges that prison populations are going to face, and you and I had signed a letter earlier in the week to Governor Wolf calling on early release for certain classes of prisoners. There's already reports of prisons around the country facing lots of challenges. Do we have the political will in this moment? And this isn't just for prison populations, but for people who are homeless and other vulnerable people who are living on the edges of society. Where's the political will? Is there the political will to deal with these populations?
I think it depends on the location, the state, the municipality. Certainly at the federal level, that's, to me, it's just a straight no. There's no, political will. What is political will when you don't have, competent leadership? But at the state and local level, there may be some innovative solutions happening. I know that, there are ideas out there to repurpose, say, hotels, or at least set up tent sort of cities for folks who are street homeless, to get them, into some shelter away from others, and not on sidewalks. In terms of, the immigrant detention facilities, those are I really worry about those places, since there's very little oversight already. And, the notion that these kids who've been separated from their parents are going to then have to go through a process, go through COVID on their own potentially is heartbreaking, and it's wrong. It shouldn't be happening. And so I've got multiple concerns from prisons to detention facilities and to the homeless populations that I've not seen really any discussion in a systematic way about how to handle these vulnerable populations and to provide them the safety they need and deserve. But I do think there are states where there is political will. It's just they need the resources. And so, again, this maybe we'll come back to this issue of the states and the federal government and their, the importance of a healthy relationship there. But the states are barely have enough money to just buy a handful of ventilators and produce like masks and things and buy these things. So it's going to come down to a federal response, which is at this, is anemic at best.
Yeah. So I want to get back to the political challenges in a moment, but I want to ask you one more question, because you mentioned how in many ways what's going on certainly in New York right now, and has happened in Northern Italy and in China and may happen here in Philly, are battlefield conditions for healthcare workers and the decisions that they're going to have to make. How do you see physicians and other healthcare workers getting the types of support from hospital ethicists and others who can help them think about those kinds of decisions that they're going to have to make?
Okay, so good question. I mean, we've already sort of begun the process of creating policies. So there are some policies now that have been developed across the country in collaboration. Multiple health systems have worked together, and bioethicists have been involved and have led the process of creating triage policies and procedures. Some of the procedures involve the role of an ethicist or a three-person triage committee to help the attending physicians make tough choices, and that would be kind of like an ethics consultation service specific to triage. So there are like, policies, procedures that have been drafted and are being used probably in New York by now. In Philadelphia, in the next few weeks, we'll probably see these policies being used. And so the professions, bioethics has, as a field, has generated a lot of really valuable information in a very short amount of time and created model policies that can be used by health systems if they have the right personnel in place to use them. Otherwise, it'll end up being individuals who have to make these choices. Oftentimes without family members present, because you can't have visitors. So it's a very, very sad situation, very difficult situation when you're thinking about taking a resource like a ventilator off of a person or out of a person and putting it into someone else, and knowing that action will kill the other person. Like, that's grueling, difficult, but it is a necessary decision given the realities of the resource scarcity.
So we do have a question along those lines a bit that I want to read to you. Doctors in countries with national healthcare systems in Italy and Spain, for example, are having to make tough decisions about who gets resources such as ICU beds and ventilators. These are mostly, with some exceptions, made using the criterion of life expectancy, not considering ability to pay, insurance status, etc. How do you anticipate these decisions being made in the private side of healthcare in the US, and do we anticipate other ethical standards being used instead of ability to pay? And that's from Osama Bilal, who's a faculty member here at Dornsife.
So I don't, the policies that I've read and the ones I've kind of contributed to don't address ability to pay at all. I mean, I think with the pandemic, that's not going to be an issue at the bedside for ventilator allocation. People aren't going to say, oh, they're private insurance versus their Medicaid versus their uninsured. That's not going to come up. I don't think. The issue's more upstream, and it'll be ability to pay to get to the hospital, to be seen, to have a physician, a telehealth physician. You know, these are the disparities that'll happen well ahead of the triage choices. You know, I think, and so you know, my worries around ability to pay happen at an earlier stage in the process. And I don't really worry so much about ability to pay vis-a-vis, you know, the critical moments of triage. It is true that other countries have, you know, single payer or more socialized forms of healthcare, but I think what this is, and they're facing these choices. I don't think any health system, no matter if it's private, you know, primarily private or hybrid as ours is, to socialized, can escape these kinds of decisions unless they've had a large stockpile of ventilators on hand. And many did not. And so, you know, trying to figure out who gets these resources is a universal and global problem. It just so happens that our country is weeks, if not months, behind that discussion. And so, you know, the decisions that other countries had to make, we're now having to make, but you know, at a magnitude of tenfold perhaps, because we weren't even prepared. So the bottom line is, I don't think that the criteria around payment is going to be something that we need to really worry too much about. I can't imagine any of my colleagues even thinking about that in the moment. But more upstream concerns around the ability to get diagnosed, get tested, get the healthcare you need well before you're in the ICU. That's where the ability to pay problem comes up.
Great. Sorry, I'm being blinded by the sun here, which is coming through one of the windows that I get to look out at into a fairly empty world right now. Janet, and thank you, Dom. We'll come back to ethics in a few minutes. Janet, I just want to switch over to you for a few moments. There have been lots of histories of epidemics throughout time. One of the things that strikes me in many of those are the messages of how these moments in our history change us and change our societies. Everything from, you know, cultural changes to the way in which the bacteriological revolution and the epidemics of the late 19th century changed things as simple as, you know, the structure of bathrooms and toilet bowls, you know, moving from wood fixtures to porcelain so we could better identify and clean germs, and get rid of carpeted bathrooms, which were certainly reserved for the elite, but also are a strikingly disgusting thing to think about. And also some of the products at that time that came about, from disinfectants to soap, that were marketed in a way that often othered certain populations. So if you could take a moment to think about, you know, through that with me, about both the historical changes that were wrought in the wakes of events like the bacteriological revolutions and those epidemics from the late 19th and early 20th centuries, but also to talk about, and Dom, feel free to jump in here, the way in which the current pandemic, in either a hopeful or pessimistic way, might change who we are as a society, and certainly change us more locally and individually.
Well, let me say something that's maybe a little controversial, that one of the consequences of that bacteriological revolution was to focus our emphasis from collective public health measures. Let's have clean water out of the tap. Let's have a sewer system, to individual hygienic practices. One of the ones that came out of 1918 was, we don't spit anymore. You don't walk down the street and see lots of people spitting anymore. So we did learn that behavior. But a lot was put onto individuals now, right? To buy the right products, to keep your house clean, to eat the right food, to, you know, and then later on it becomes to not smoke cigarettes, to not eat bad food. We've individualized health practices and maybe underfunded the public health infrastructure we need. So that was a change that came about. And now I think we're going to start, I'm afraid, but we may begin to see as the death rate climbs, well, those are people who didn't take care of themselves. Those were people who smoked and had bad lungs, so of course they died of the COVID-19. I'm concerned that the 20th century, and especially the 21st century, has been one in which health has become a private matter. Now, that's not in and of itself bad, as long as we maintain the public health responsibilities for education, for addressing and I would say that income disparities are a public health problem as well as an income problem. Environmental health, what do our communities look like? Are we living next to plants that are emitting at night, that are damaging our lungs? So it's kind of a paradox that the better tools we have in the medical arsenal, the more it's been put on us to take care of our own health.
I think that's a fantastic point. And, I would, the cynicism that I'm feeling in this moment, you've summarized nicely, particularly, when we were talking earlier about health disparities and about how those underlying conditions that we see in poorer, more vulnerable populations are going to be used to blame and stigmatize those populations. And if that is the case, we have learned no lessons from the past, and will set out on an even more dangerous course in terms of hardening those disparities and not investing the resources that we need to lessen them, especially in the wake of a crisis like this. Dom, I'm wondering if you have any thoughts in that question broadly, and particularly how it might change how we think about ethics and in a post-COVID world.
Well, I mean, let's start macroscopically. I think we're going to begin to hear stronger, more sort of vociferous arguments in favor of universal health care from folks that you might not expect. I mean, you'll have, of course, the left progressive wing of the Democratic Party redoubling its efforts to make the case for Medicare for all. But I think you're going to start to hear moderates say, look, this is actually a national security issue. This isn't just a healthcare issue, and we need a better safety net. And so we might see a public option based, solely on this notion that, look, if the economy shuts down, we need a marketplace for people to go and get health insurance. And so, and of course, the federal response right now is to not open up the Obamacare exchanges for whatever reason. They could do that and allow people who have lost their health insurance to buy, health insurance on the exchanges. So there'll be, at a macroscopic level, I think, ethical, calls for a more robust public option, if not a system of Medicare for all. And then as you get down to institutions like hospitals, we're going to see new policies that have been developed for triage in these situations, used to consider other matters, or used as models for other kinds of limited resources that may exist. And I don't necessarily think we're going to be rationing everyday things, but it might come, we might say, we learned this from the COVID epidemic about how best to allocate ventilators. We should apply this type of thinking to organ transplantations, where there already is an allocation scheme, but is always being refined and developed. So we're kind of getting a crash course in allocation ethics in real time, and we're going to be able to see what works, what doesn't work. At an individual level, I think people are going to begin to understand that we are all in this together. And it is actually every decision you make to go out of your house is an ethical decision. So when you decide to go get a pint of Ben & Jerry's at Wawa, you are making an ethical decision in the next month or two or three. And that is, you are deciding that your ice cream is worth exposing yourself to the coronavirus, or potentially spreading it if you are in fact a asymptomatic spreader. So everyone should assume they have the virus, is how I would say, how I would put it. Everyone should assume that they are infected, or they and they're shedding virus. And so so at the individual level, every decision you make will be an ethical choice, whether you like it or not. And we need to grapple with that reality. We need to realize, like, we're going to be doing risk mitigation for a long time now, and that's going to have to become part of our psyche. And making these trade-offs, you know, it very well might be ethical to go get that pint of Ben and Jerry's if your mental health needs it, like it might for me tonight. You know, and you might be able to make a case, well, look, if I'm going to be super depressed, this is one way to self-medicate that's safer than other ways. So maybe I'll take take that risk and do it. Otherwise, I won't. So, you know, the Ben and Jerry's example is meant as a, you know, more as a fun thought experiment. I don't think anything's really worth that, but, well, maybe that's wrong, but maybe, but the point is, every trade-off we make is going to involve risk to self and other. And so we need to, you know, kind of begin to rearrange our brains to think that way for the next several months. And then, you know, thinking about our kids and our families and our parents, you really, you know, you might want to give your kids a hug, but if you are currently symptomatic, you just can't do that. You might, your parents, you know, your kids' grandparents, in my case, my parents, might be pleading with you to see the grandkids, and they can, but they have to stand, the kids have to be in the car, and you have to be, you know, 10 feet away. Yeah. You know, so these are things that we're just going to have to do. And these are ethical decisions that we're going to have to do on a minute by minute basis.
These are all great points from you both. And there was a question that came through from one of our great MPH students, Tina, who was asking about what are some of the blessings the pandemic may bring to our healthcare system and society over the long term, particularly in light of ethics. But I think you started to address some of those in your question. Would there be anything you wanted to add to that, or you think you hit that?
Well, you know, I would also want to say, in terms of blessings to health, I mean, Zeke Emanuel, who's my chair, he said, you know, when he was being trained in the 80s, the HIV epidemic had just started, and he witnessed doctors refusing to treat patients, and clinicians, you know, saying, I'm not going to go near those folks. I'm not going to treat these people. And, you know, many did, but there were cases, you know, many that didn't. And in some ways they were accommodated. And so, you know, he made the point the other night that he's not seeing that now. And I think that really highlights a you know, a grand transformation in American medicine around taking care of folks who have infectious diseases that are highly contagious. Part of me wants to say that's because, you know, we really put a lot of time and effort into bioethics in medical schools. And so now we have doctors who are doing the right thing. Maybe that's part of it, but I do think that's a bright spot. I mean, it's, you know, just seeing these folks, these heroes really, who are donning masks and going into the fire, essentially like firefighters charging a burning building, is really inspirational. And these are the heroes that we need to hold up. I mean, physicians, nurses, allied healthcare professionals, these are the people that keep our society safe and functioning, frankly. And so, you know, recognition of that is, to me, you know, that's a priceless sort of thing that you really can't, you know, produce without some catastrophe like this. Not that you would ever want it, but it does bring that, you know, bright spot.
It's a great point. And I, you know, it's something I think a lot of us have been thinking about in terms of how we're contrasting both the response of frontline healthcare workers and also people who, you know, have been, for the most part, behaving and staying home and listening to leadership, certainly at the state level, in most states at least. And there's something I think important about that as atomistic and individualistic as our society can be, and rugged American individualism, in moments like these, we as a people tend to step up, and most of us are doing the right thing. This, of course, doesn't discount the fact that our president carried on for 6 weeks, that coronavirus was under control and would be gone. And here we are on April 2nd, and of course the fire is raging. I want to turn back to history for a moment. We've got about 15 minutes left. And one of the increasingly challenging problems of this virus is that the number of asymptomatic carriers or people with such mild symptoms they don't even notice that they're sick, thus making them, for all intents and purposes, asymptomatic, seems to be astronomical as compared to other illnesses. There was some data out of Iceland yesterday, the day before, where they're testing a very large portion of their population, which suggests that as much as 50% of the population there who were tested could be asymptomatic. That's a big number. And there are certainly some historical precedents to this. And Janet, I'm going to turn back to you for a second, maybe to tell us a little bit about the story of Mary Mallon, otherwise known as Typhoid Mary. And she was an asymptomatic carrier and had a not very good experience. So if there
were many asymptomatic carriers of typhoid. It lived in the gut, and which is why you see signs about washing your hands pre-COVID, because you don't want to spread it through food handling. I'm going to call her Mary Mallon as you did, because we don't label people by their diseases. And there were many asymptomatic carriers. Mary Mallon did 2 points to say. One is she did not really understand, I think, that she was causing people to get sick and die, and eventually was confined on North Brother Island in New York to keep her away from people. Whereas other asymptomatic carriers who happened to be male and were food handlers were given more education and allowed to be free. So there's a tremendous gender disparity there. But I think what it also tells us is the importance in that case where we listen to people with scientific knowledge. And we acted on science. And one of the things that has come out of understanding asymptomatic carriers, as we see now, of understanding epidemics, is relying on people with knowledge. We've chosen not to do that until maybe recently in this administration. And I think that's really an interesting sign that we're in the 21st century. We have tremendous medical tools. We have knowledge about viruses. We have a worldwide epidemiological program going on. And yet the people we put in charge of dealing with a public health crisis, a pandemic, are not people who understand the science and the public health matters that are before us. Mary Mallon didn't understand. She needed to be educated. She was stubborn. She didn't want to learn. She had to be confined. And there is legislation everywhere that lets us confine people. The Supreme Court upholds that. But in a sense, we've turned away from that model of saying the scientists are in charge of our laws and our public health practices to saying, let's push them aside. Let's let politicians say, build a wall, when any physician or any public health expert will say, viruses don't recognize state lines. They don't recognize national barriers. So I think that's really been an interesting lesson for me, is to think about how we've entered an age of distrust of science, and the consequences, I think, have been enormous and deadly.
Yeah, I would just chime in there and say, every day I watch a White House briefing, which is not every day, thankfully. I need to keep my sanity, but it reminds me of Chernobyl, the miniseries, the actual events, which I remember as a child. But we're living through our own Chernobyl right now, where there are politicians who are not even politicians, but more like toadies and stooges to the president, essentially agreeing with nonsense that is getting people killed. And that's kind of like what happened in Chernobyl, when, the Politburos and the committees just tried to make things look good for the next level up on the political chain of command, in spite of the science and in spite of the scientists who were saying millions of people could die. And that's where we are as a country. We are in our own Chernobyl right now. And unless we get our heads out of our asses, and politicians begin to understand that they don't know everything, especially the president, and begin to turn over control to folks like Anthony Fauci and the folks that actually spend their lives studying these issues and the science, we're in big trouble.
I'd say we are in big trouble.
Yeah.
It's not unless, it's as we are here, we are in very big trouble. And at the same time, our politicians are cutting our CDC budget. They were told year after year they needed to put more ventilators in the National Strategic Stockpile and to have funding to get rid of the old stuff that had expired and to put in new stuff. They were told to keep people in the National Security Council who were experts. They were told to keep epidemiologists in the field. They ignored the knowledge, the people with the knowledge, the people who make the knowledge about a very serious, deadly threat to our way of life. And they ignored that. And the question is, will there be consequences for what they have done? I'm a historian, I don't do future. But it seems to me we're at a pivotal political moment. Our social life is going to change. Our economic life is going to change. Will our political priorities, will our respect for science change? I wish I had an answer.
Yeah, I think these are all points that resonate deeply with, I suspect, our audience and with many who live in our world, which is, one based and rooted in science. But how do we get, and this is a discussion that in some ways we've all been having over the last few decades, as we've seen, as you've both said, science become more of a suspicion than something that can drive our lives in a positive way, within reason, of course. But how do we get the wider public who are suspicious of our work to understand its importance? Is it that we let this play out and hopefully people wake up, or are there more intentional actions that we can be taking in addition to being in discussions like this and speaking out to the public? What role do we have as academics and scientists to help reframe this discussion so that once we are past this, we can be prepared for the next one? And I think, among the things that have outraged me over the last 2 days, and Dom and I were going back on email earlier about sort of the deep anger that we are both feeling right now because of the circumstances that we find ourselves in that are, for the moment, beyond our control. Things like the governor of Florida saying that he finally decided to issue a stay-at-home order because of President Trump, a change in President Trump's demeanor, or the fact that there was a literal how-to pandemic guide that was given to the Trump administration during the transition in 2016 that they essentially ignored and threw out the window. How do we move us back into a better place? Is it simply becoming more political as a field and as individuals, or are there things that we can be doing individually and together? And I'm looking at one of the questions from our students. What can students do at this point to find a better path forward and simply a path out of this disaster?
Well, if you don't mind, I'll just, the first, I think the most immediate need is to remove the president, actually. And I think if students begin to call their congressperson or their senators and just say that, this is just a crisis of catastrophic proportion and we need competent leadership. Not to say that Mike Pence would be much better given his record on public health matters in Indiana, but at least he wouldn't be more preoccupied with his Facebook followers. I would say next is that we have to have a sort of longer term strategy to begin to educate our children about public health matters, but mostly, more fundamentally about critical thinking and being able to detect bullshitters. And that's that's the key, is we need to equip our kids with really high-end bullshit detectors in their brains so that this never happens again, so that we don't have a demagogue who's anti-science take over the country and then face a public health catastrophe without really any true leadership. And so in the short term, we've got to make some major changes. And of course, in the midterm, we've got to elect somebody who, will be pro-science, at least. Fact-based would be nice, actually. And then longer term, we've really, I think starting in elementary school, teach logic and critical thinking so that kids will not be, snowed by ideas that are completely farcical. And that's what the president's entire political career has been built on, I think, a lot of fantasy and people buying into it. But, that might feel good in the moment and when you're, thinking about voting and there's an election. But when there's a global pandemic, fantasy is dangerous. We need reality.
Thank you, Dom. We have a couple more minutes, and if there are any more questions that are going to come in, please send those now. I want to give Janet a chance to address that bigger question quickly, and then we'll answer maybe one more question and then close.
Well, I echo everything Dom has said. I actually have retired from my teaching career, and I now spend the bulk of my time engaged in political activism because I feel we're in the midst of a 25 alarm fire, and I want to change things personally, and I want to bring other people into that with me. And I want to continue to educate young people through other means as to thinking globally about our needs as humans on a planet we share that is getting less and less hospitable. In the short run, to deal with this pandemic, not through hatred and fear, but to just support those volunteers who are out there in the emergency medical corps and helping people get food, all of that, because good people are out there doing good things, and I want to shout out to them as well. So I'll go back to you, Michael. You can wrap up.
Yeah, I think that's a great point. And one of the things that we've been talking about at the school and in our departments is how can we leverage our expertise to help move these types of things along. And we're doing stuff like this. And I know a lot of people are out writing op-eds, talking to journalists, and anything we can do now to get out our information, I think, is incredibly important. I also think, after this, we're going to have to redouble those efforts and not let our guard down. There will hopefully be a reckoning, but one thing that I think we as public health interested and focused individuals need to think about are also the failures of public health in this context. How did we get to a point where we are seeing, this complete dismemberment of public health infrastructure in our country, which falls to our field as well. And, that is for another discussion. But we can blame politicians, but I think we also need to look at our own fields and think about where we came up short to make sure that going forward we don't get into trouble like this. I'll give you each a closing word or two, and then I'm going to say a few words and what we can say goodbye. Dom, anything?
Yeah, so I would, so one last thing, and this is, I wish it was more of a positive note, but we're in a global pandemic. So part of me wonders if this isn't the big one, but rather is sort of, a wake-up call. Almost, I think of it almost as a societal vaccine that's kind of telling us we need to get ourselves prepared for the bigger one, the big one, whatever the pandemic or even global climate change. So if you think about this pandemic, it's a big deal. It's catastrophic, but could there be a worse one? And if so, maybe this is our chance to figure out how to get our systems in place now so that doesn't happen as these, as some of the bacteria and viruses are unlocked from glaciers over, that we've never encountered and could be seriously contagious and deadly. We need to be ready. And so this to me is a sort of dress rehearsal, not to minimize it, but it could be worse, and we should take take that possibility seriously and get our systems in place now, because if we're not going to, if this happens again and we're still this surprised, something's very, very wrong. So this needs to be seen as a call to arms for larger, worse pandemics and for global climate change.
Agreed. Janet, one quick word.
One quick word. I will just say amen to Dom. There is no planet B. There is no planet B. That's our motto. This is the only one we've got, and we have to arrest climate change. We have to arrest failing political systems. We have to arrest apathy because we don't have any other choice.
Yeah, I'll close on this note, which echoes the two of you, which is one of the things that's been striking to me in talking to non-historians is how could this happen? This is so shocking. I've never, the Earth has never experienced anything like this, which of course is absolutely not true. We've been through, we've lived in a relatively privileged era where pandemics have either not affected us personally or have, with Ebola as an example, not taken hold globally. But pandemics have been part of human history and have reshaped our societies over and over again. And if there's one thing you can take from this discussion is to go pick up some history books about the history of infectious diseases, whether it be the 1918 flu or the HIV/AIDS pandemic, and learn about the way in which diseases and our reactions to them, both personal and political, have shaped our lives and our societies. So I will close with that. We will reconvene here at Drexel's Dornsife School of Public Health virtually on Monday, and Professors Joe Amen and Alex Eze will be talking along with our Dean, Ana Diaz-Rue, about the global implications of the coronavirus outbreak. So thanks to everybody. Thanks to Dom and to Janet and to all of you for joining us for this hour. I think at our peak we had well over 50 folks listening. So this will be posted online. We'll get some more listeners. Please share it widely with your friends and your family members who continue to disbelieve that social distancing is not a really important thing at this moment. So thanks again, everybody. Have a good night.
Thanks, Mike.
Thank you.